Hello, everyone. Thank you for joining. Okay, I think we can get started. Thank you so much for joining today's session. In today's session, my name is Jasu. I work as a Senior Technical Operations Manager here at Commure, more specifically on any automations related to denials and rejections. In today's session, we're going to be talking about our recent AIR automations, more related to eligibility denials and coding denials. How do we prevent them with our current automations and what's coming in the future? And we're going to be talking about this one by one and explain to you how it shows on AIR and how you need to interact with them. Okay. Before we go start the session, if you on Zoom, on the bottom, there's a three-dot button for more. If you click on that, there's a Q&A button, as you can see on the screen over here. And then you can ask questions throughout the session, and then we'll have a dedicated session for Q&A at the end of the session, and then we'll get to the questions. Okay? All right. So in agenda today, we'll have some overview and we have an engineer, Ritesh and Elliot, joining to talk about the eligibility and enrichment, what is enrichment and how it works, what are all of the insurance routing strategies that we have, how it shows on insights, and how we should, when the error shows up, how you should look at it and how you should deal with those claims. And I will be talking about the coding validations that we have recently introduced in our system and what's coming in that. And we have a 10-minute at the end about Q&A. Okay. So the reason that we wanted to automate denials and rejections, it's one because in ideal world, we just submit a claim and it gets approved immediately and the revenue is coming back to the provider immediately. But that's not the case, and we do get denials and rejections. And as a company, we track a clean claim rate, aka first pass rate, to track how clean the claim is going out. And the cost of working denials, it's quite high. And it not just working a denial and sending a correction to the insurance companies, but it causes delays in the reimbursements too. As we analyze what are the top buckets in our affecting our clean claim rate, it's one, eligibility, patient coverage related denials, and the second, it's coding related denials. What it means by eligibility is patient can be inactive, it's sent to the wrong payer, wrong subscriber details are submitted, etc. That is making up our top one bucket of denials and rejections. And then next is coding for invalid diagnosis codes, modifiers, CPTs, etc. So our objective when doing these automations was to how do we automate this, prevent this upstream before it goes out so that we can improve our clean claim rate. At the same time, if it comes as a denial rejection, how can we deal with those automatically and assist you in solving those denials rejections in a more intelligent way? Okay, so I'll hand off the slide to Ritesh and Elliot to talk about the eligibility enrichment.
Yeah, sure. Thanks, Jasu. Hey, everyone. Thank you for taking the time out to join today. We hope to make this session super useful for you all. And I'm Ritesh. I'm an engineer on the RAD team at Athelas. RAD stands for Rejections, Appeals, and Denials. We're the team responsible for building out a lot of the core claim rework automations. This includes our rule engines, denials, rejections automations, appeals automations, and just making sure that claims that are denied or rejected are either one, like worked efficiently in an automated manner, such that we reduce any like manual labor costs or any inefficiencies in the process, or two, I think this is even more important. It's preventing denials and rejections upstream in the RCM funnel. And both of the projects that we're going to talk about today kind of are part of that initiative where we try to prevent issues happening upstream. So eligibility enrichment was one such effort which we took on early last quarter. Um, and the goal of enrichment was to automate insurance and patient detail corrections upon the initial claim submission. Before I get into like what eligibility enrichment is, I think I want to give some context on why this was an important problem for us to solve, right? So what we noticed in our data when it comes to claims, when it comes to denials and rejections, we saw like a huge skew in terms of the type of denials that we're getting, right? So 34.7% of all of our like denials inflow was eligibility or coverage or like wrong payer related. 48.3% of rejections were like coverage related. So you can see that already these are like significant buckets, right? It was the biggest bucket that we had in our inflow. And if we compare that to what Jasu was talking in terms of the clean claim rate and the FPR, the first pass rate, it had a negative 3.6 impact on FPR. So all this to say is that it's a very big bucket, and that's why we wanted to tackle it upstream. Um, we obviously have automations downstream after a denial and rejection occurs to solve for these denials and rejections in an automated manner. But I think early last quarter, we fundamentally like asked the question, like, can we build automations to fix these issues as upstream as possible? And the way we would want to go about doing it was to leverage a lot of the data that we have in our system, right? And proactively fix these coverage issues to prevent these denials and rejections. When I'm talking about data, we're talking about like eligibility check data. We have, prior approvals. So all of this data is stored in the Athelas system, and it was the main goal of this effort was to leverage all of that to prevent any issues downstream. So that's just a little bit of context on why we took on this effort. Um, it takes me to what is eligibility enrichment, right? Um, so enrichment is a set of strategies. Like I would just think about it in that sense. I'm sure a lot of y'all are like following the FIFA World Cup right now. So you have football teams. They obviously have like plan A, plan B, plan C. If plan A doesn't work, they go to plan B. If plan B doesn't work, they go to plan C. And you have like different strategies to win a game. Um, that's similar to how we think about claims and claim validation. You have like a bunch of checks, you have a bunch of validations, and you want to incorporate all of this to make like a very informed decision before the claim goes out so that the claim is in the best possible state for an approval. Um, so what we try to do is, like I said, like leverage a lot of the data that we have. So it involves reading the eligibility check response, cross-referencing the patient's like claim history. Obviously, like a lot of these plans and insurances, they're very patient specific, right? So you want to be as specific as possible. When it comes to making any changes, and then correcting the payer plan and subscriber details before the initial claim even leaves our system. So this is way before even like the clearinghouse is rejecting us, right? We want to make sure that the claim goes out correctly to the right payer. And this has like a ton of benefits because you're essentially making sure that you get to the right payer in a timely fashion. So a lot of like timely filing issues could be prevented. You're also making sure that you obviously like don't have to like rework these claims at the end if they end up getting denied or rejected. So that is what eligibility enrichment is about. And like I mentioned, there's a set of strategies that we have. And if you look at the 4 blocks on the slide, these are the things that it kind of does. One, we want to run eligibility checks before the initial submission. We obviously run it at the time of appointment as well, so we do leverage that data. But if there is no eligibility check for this claim, we actually like proactively run a check just so that we can like incorporate that as a data source. We then use the claim history. So there obviously patients will have like prior approvals. So learning from those prior approvals to make sure that we have like a really good decision on this current claim, that is also another input to eligibility enrichment. And then once we combine all of these inputs with a lot of like validations and guardrails, we then make sure that we update the subscriber details correctly. We fix policy numbers using data that has come straight from the payer through the eligibility checks. And then we also fix routing, right? Like obviously the EHR, when we think about the EHR, it is inherently a data entry tool, and data entry tools are prone to a lot of errors. So you can't directly trust the data that's coming through. You want to also like verify, make sure that we have all of the right details. So that's the main purpose. And so I just want to like quickly walk us through what each of these like strategies look like, right? Like what does each of them do? So the first one, so the first thing that we look at is looking at the prior insurance history of this particular patient, right? So if we see that the current insurance has been previously denied or rejected for coverage, and this is like recently, we run an algorithm to actually automatically find other approved claims of a patient and verify if we can update those incorrect insurance details automatically. We see if we can use the data from the approved claim of the patient for the current date of service. And we obviously like validate this with another eligibility check for the current date of service. We also like have like other guardrails in the system to ensure that it's not swapping out incorrectly. And all this is like it is to integrate with what practices usually follow, right? Like for instance, in a PT practice, you could have a patient who comes in like 5, 6 times a month, right? Like that's like, or even more. And you have 5 or 6 different encounters. And previously what used to happen is like if you made a mistake on like one encounter, that mistake basically cascades across all of these different encounters, and it's just like unnecessary denials, right? Like if you're sending it to the wrong payer or with the wrong member ID. So what we want to do is essentially use this approval to prevent those like additional denials and rejections from happening, and we've seen like really good success with this approach. And so the goal is, yeah, the goal of this strategy is essentially using a lot of the history that we have in our system already. After that, the other strategy that we have is, let's say we don't find another approved claim of the patient, right? In that case, obviously that is a data source that we don't have in this case. So we will actually look at the eligibility check, right? So like I said, we run eligibility checks as part of enrichment. And I think there's a fundamental like misconception where we think that, okay, say the eligibility check is saying it's active. That means that if we route it to this particular payer, that claim would get approved. But actually, there's like a ton of nuance that exists in the eligibility check. There's a lot of like data around the benefits. There's a lot of data around the plans, effective dates. So all of those are like not accounted for when you initially map the insurance, right? We kind of take care of that as part of interpreting the eligibility check. So when we see that an eligibility check is active, we essentially run it through a bunch of different, think of these as like sub-strategies, right? And these are essentially scenarios where we are looking for particular signals in the eligibility check that can prove to us that, hey, this is the right place to send the claim, or these are the right details to send on the claim. So our first strategy, for instance, is coordination of benefits. So in the eligibility check, there's a lot of scenarios where they actually tell you who's the right primary payer, right? So we do have cases where primary and secondary is kind of swapped for the patient, and you want to ensure that the benefits are coordinated so that you can prevent CO22 denials. So we essentially look at this data within the eligibility check to fix that order and submit the claim to the right insurance on the first pass. We then also have Medicare Advantage plan detection. So again, in the eligibility check, when we run eligibility checks for traditional Medicare, for instance, we do find signals of Medicare Advantage plans. So this would mean that you need to route the claim to the Medicare Advantage plan rather than traditional Medicare, and then that prevents CO24 denials. This is again similar to Medicaid MCO. Um, a lot of claims we noticed were being routed to traditional Medicaid, while actually they should be routed to the managed care organization. And again, so we follow a similar strategy where we try to find the signal in the eligibility check and we prevent CO24 denials in this way. Um, the next strategy that we have is for retired railroad. Again, retired railroad, in some cases, you need to route the claims there directly. So we look for signals there. Um, we have a strategy for Medicare DME. So the DME jurisdiction for Medicare actually changes or gets updated quite often. The DME codes get updated quite often. So you need to route claims based on these two inputs. So our system now automatically actually detects these jurisdiction changes, these like CPT code changes, and we make sure that you're routing the claim to the right Medicare DME jurisdiction. And only the codes that are DME codes are routed there. The rest are routed to like traditional Medicare. So all of those like guardrails are already baked into the system. BCBS California, there are like a ton of like rejections and denials around, are you sending it to Anthem Blue Cross? Are you sending it to BCBS? So we've again like have like a strategy around looking for a particular signal in the eligibility check, and we try to prevent this. Currently, BCBS routing is limited to California, but we're also looking to like expand this across different states. Obviously, BCBS is very different across different states, so we kind of want to treat that differently. And then we also do independent physician association IPA routing. So in a lot of cases, you want to route the claims to the IPA plan directly instead of the health plan. So we take care of that. And the last sub-strategy is United Healthcare. So you might have noticed in practice that when you route claims, sometimes United Healthcare, you get a ton of like B11 denials. That's because we do not like actually route it to the right delegated entity or the specific like UHC plan, like Optum or WellMed. We also like run checks with UHC, get that data from them, and then try to like route the claim directly to the delegated entity. The advantage of this is one, you essentially reduce your time to pay, right? Like you don't have to wait for UHC to actually auto forward these cases. And two, you're kind of keeping that control over like where the claim is going on your end rather than depending on like UHC actually like auto forwarding it or not auto forwarding it, right? So all of those things are actually accounted for in the system. And the next part that I want to talk about is obviously this is the scenario when the eligibility check is active. We also have solutions for when the eligibility check is inactive or inconclusive, right? So when an eligibility check is inactive, that's already a bit of a flag. So we want to actually like look at those cases. We try to proactively find other PIIs or other like patient insurance informations. Again, this is goes back to our original scenario of using prior insurance history, right? Like we want to make sure that we can use all of the data available to us to make sure that we're making the right decision. So that's how it actually works right now. So a few things I want to like highlight here is all of these strategies using like our prior data, using the eligibility check data, all of these have been like heavily back tested against like on over like 100K claims. Like there are plenty of claims just to make sure we get a very good like payer mix such that all of these strategies hold. And we saw like really promising results, right? Like the accuracy, Elliot will like talk about this down the road, but we saw like really high levels of accuracy. It was compared against an approved claim. Um, so we were very confident before rollout that um, all of these like strategies will have a positive impact, and you can be rest assured that the claims are getting routed correctly or the details are getting updated correctly. um, and the other point that I would emphasize is obviously eligibility check data again is not uniform. Some payers are like generous with the information that they share, some are not. So our system should be able to handle all of these different payers well. So we do have like a ton of guardrails baked into the system, right? Like if there is missing data or data that seems incorrect, or like sometimes the eligibility check may return the wrong data. So how do you handle all of these like different scenarios? Like these are all guardrails that are already like thought of and baked into the system. So that's another thing to call out, right? Like eligibility check data is messy, but it is valuable. So we try to like leverage it in the best way that we can. So this is just a little bit about enrichment, how it like actually works under the hood. There's a little more like complexity involved here, but I'll start. I won't talk about that right now. I'll hand this off to Elliot so that he can talk through a lot of the results that we've seen, what you should be looking out for when it comes to like visibility on air, and like any other like resolution paths. So yeah, feel free to leave any questions around this in the chat, and we will get to them at the end of the session. Elliot, if you want to take over.
Yeah, thanks, Ritesh. Hey guys, my name is Elliot. Also an engineer working with Ritesh in the same team. So I want to talk today about what has actually been delivered because the results we've seen are fairly significant. Um, as Ritesh mentioned, after like rigorous backtesting, we have built confidence that our system works properly, accurately, and currently eligibility enrichment has been live across all of our sites, essentially checking on every initial claim. So let me define what each of these four numbers here mean. So the first one is 97%. This is our initial automation approval rate, which means claims that our strategy has touched, corrected before the first submission, 97% were essentially approved by the payer. So they were corrected once by our strategy upfront, and then they were actually paid. Second one is 72%, which is our resubmission automation reapproval rate. So when a claim does still get denied or rejected due to eligibility reasons after the initial claim, we have a second pass resubmission engine where eligibility enrichment is also integrated with. And this engine also basically reworks the claim and tries to resubmit. And of the ones that we've resubmitted, 72% of these came back approved. Again, with no manual work being needed here. The third is over 280,000 claims, which is the total number of claims we've meaningfully changed. So here, meaningfully is the key word. And these are real payer plan coordination of benefits, subscriber patient details that have been changed. So these are significant changes that we've corrected to the claim and have actually been affected and approved. And the fourth is $42 million. So this is the total claim charges that have actually been paid on the claims enrichment has fixed. So this is not just a projected number, it's actually the amount of money that has been collected. And honestly, this is just the floor. On top of these dollars, every one of those is a claim that simply doesn't need to be reworked manually by, you know, chasing a denial or filing an appeal. And also another thing to note is that there's no revenue loss to timely filing deadlines because the claim goes out clean the first time. And the cash also comes in faster because it's paid on the first pass instead of weeks later after a denial and a resubmit cycle. So this eligibility enrichment isn't something we just like to have something running on the background. It's actually directly protecting the revenue that would otherwise leak out or um, we would have to chase over a long period of time. Next slide. So how can we see if and how claims have been touched by eligibility enrichment? And this is something we provide full transparency in error through two complementary signals, that are designed to be cross-referenced. So the image on the left shows the page where we preview a submission. And as highlighted on the red boxes, these sparkles, these usually indicate details that have been changed through any of our automations. So like any rules, and eligibility enrichment is also part of this. So in this case, we can see that the date of birth of the patient and the subscriber has changed. And this can also be cross-referenced from the notes from the eligibility agent. And the note actually contains an explanation or the reasoning behind the changes that have been made. So after cross-referencing these two places in our error, it will give you a complete picture, verifiable picture that documents what has been corrected and for what reason. So there is a clear before and after that we can take into consideration. Yeah, and as Ritesh mentioned, eligibility data returned by payer is often inconsistent. In some cases, like this check confirms that coverage is active, but the correct payer or plan to route the claim is not immediately clear. So in these cases, we kind of flag this as a warning, where instead of risking submitting to the wrong payer, these types of claims are held under review by our team, and they will actually be auto-submitted after it goes through another round of confirmation in our team. So one thing to note that is that these suggestions are not the payers we will auto-submit to. For instance, if there is a workers' comp payer or a dental payer that is being suggested when the claim is clearly not um, for a dental claim, we have like these extra checks and guardrails in place so that the billing and claim insurance types are matched. And after all these signals align, then our team will auto submit it. So again, this is not something where manual intervention is needed. However, the warning displayed um, sometimes will need manual action and override only if, as the warning message says, that we are confident that the payer is correct. Then, like these warning messages can be overwritten. So this is something to keep note of. So yeah, so where is this headed next, and what are the next steps? First, we are continuing to sharpen the automation. So as we've seen the numbers, we expect these numbers to only go up because eligibility enrichment has only been rolled out to all sites for a couple of months, and we've been consistently finding more ways to improve these numbers. So improving that last mile accuracy and expanding the edge cases that we might have missed, but and pair plan scenarios that we can resolve fully on our own. So even fewer claims need to hold and review. And second is on-demand reporting. So today the changes live on each claim. We're planning to build a report that can be pulled anytime that shows every correction eligibility enrichment has made across all the claims. So payer plan coordination benefits, subscriber details, and we'll write these corrections back into the EHR. So it's not just the claim that's right. So the patient records actually also get updated and stay accurate and in sync. And third will be a review process. For sites that want more oversight, we're adding a workflow to review enrichments changes so that you can either approve or reject them before they're actually applied. So we can run this at whatever level of control each site is comfortable with, from fully automated to fully reviewed. So yeah, that's all for eligibility enrichment we have today. And yeah, we'll move on to coding side next.
Okay, thank you, Ritesh and Elliot. Okay, so before moving on to coding, we have seen after rolling out eligibility enrichment on the initial claim, we have seen significant decrease in the eligibility denial rejection inflow so far, and hopefully we'll see even more in the coming future. And what we're planning for what's next, the review process, an on-demand report, etc. So these are all came from the feedbacks that we have collected from our clients and our colleagues. So if you ever see a claim where it feels like it should be a different, or you want like a different process or anything, any feedback that you can share with us, your feedback is really valuable to us in driving the next roadmap and what we're going to be building next. Okay. So coding validation. So we have introduced a couple of blocks on the claim before it goes out to prevent coding validate denials, but also we are planning a couple of automated ways to suggest coding changes on the claim. So we'll get into that. Next slide. Okay. So why coding? Eligibility was like a huge bucket as explained by Ritesh, but coding will be one of the next buckets. 19% of the denial inflow is coding related, 14% of the inflow is rejection related. And for first pass rate, it's decreasing the first pass rate by 1.6% if you take all of the coding denials and rejections. So what I mean by coding is related to diagnosis code, CPT modifier, sometimes service unit related, sometimes could be related to NDC too. So there are tons of payer policies available from CMS and different payers and AMA as well. These gets updated on an annual basis, sometimes on a quarterly basis. Keeping up with those is also one challenging thing, but also at the same time, just working coding denials, rejection in general is like a complex process that requires a coder to review this or someone who is experienced with medical coding to look at those and then fix it. And yeah, so we asked the question, how can we leverage all of these official guidelines to prevent these denials rejections? But at the same time, how can we use all of these information policies available to suggest you a coding, accurate suggestion for coding that you can use to fix your denial rejections? Okay, next slide. Okay, the first block that we have introduced so far is ICD-10 coding validations. There are 4 different blocks. I'll explain all of them now. These are all the guidelines that are that's given from CMS on an annual basis. So CMS owns the ICD-10, CM, and PCS codes, and they release those guidelines on a periodical basis. So we are fetching all of this information from the CMS. So let's say if the date of service falls today, we will apply the guidelines that applies to today's date. But if it's a claim from a year ago, that policy from a year ago will apply to that. So we're keeping track of those effective dates and applying those accurately. The first block is excludes one conflict. So there are 2 or more ICD codes that cannot go together because they are just inherently mutually exclusive and talking about the same nature and same type of treatment. There are one exclusion to this is that sometimes you can do similar type of service, but just do it on a different body part. If you do it on the left eyelid versus the right eyelid, it would be like a different body part, or right hand, left hand, etc. So in that case, we will not be blocking because they are inherently different body parts and applied because of different reasons. But if it's on the same body part or it's not diagnosis codes that's related to body part at all, then it's just mutually exclusive, and per CMS guidelines, should not go together. So we're flagging those as a submission error currently. And the next action that you can take from here is that review the coding and see if there is if one of them should be removed or should be replaced with a different code that's more specific and that is different from the code that has a conflict. That's for excludes one. Next one is age-restricted codes. Some codes are only for pediatric patients or only for adults, only for like certain age groups. So in that case, we're blocking those cases as well. And for the pediatrics, for example, some codes are only for 8 to 28 days old patient or 28 days to certain days old patient. So we're also considering all of the day ranges and applying it based on the date of birth of the patient to the date of service. Next one is sex-restricted codes. Some are only need to be applied to female, only need to be applied to male, etc. So based on how the male, female is registered in the patient's profile, we're also blocking those cases that are absolutely need to be only for the certain female or male. Next one is invalid primary diagnosis code. Some codes that cannot be in the primary position of the diagnosis code. So some of the examples are, one of them is sequela. Sequela, the ICD codes you can identify by the 7-character being S. Those inherently explains the second nature of the condition, so it just cannot be primary. So if you find it, we will block it as well. And there are other codes like external causes codes, manifestation codes, some of the codes that is violating code first, etc., that we are blocking right now. And all of these blocks are soft blocks. What it means to be a soft block is that we will block it, and if you feel that this is absolutely necessary for the patient based on their condition and treatment, you can override it and submit so if you feel otherwise. But these blocks are necessary because these are coming from the guidelines, official guidelines themselves. But we understand that this can be patient-specific often. Okay, next slide. Next block we introduce is HCPCS validation. So for context, there are HCPCS level 1, level 2, and there's level 3 as well. For our blocks, we're considered level 1 and level 2. Level 1 is basically CPT codes. As we know, they are updated annually by the AMA. While the HCPCS level 2 are updated quarterly by CMS. So CPT codes will be all different surgeries, treatments, radiology, etc. For level 2, a lot of it could be supplies, drugs, equipments, and DME codes. Those will go under HCPCS level 2. So we get these updated effective date and terminated date from both the sources periodically, and block it if it doesn't fall under the effective date and terminated date range. So if the code is terminated for like January 1st, if you are using it into 2026, we will be blocking those. Or sometimes, let's say AMA will release the CPT codes around October when it's going to be effective in January 1st. If you used it earlier, we'll also flag it to you so you don't have to keep track of all of these quarterly updates and annually updates, etc. So you can be flagged as a submission error. These are hard blocks because these just won't be accepted. And these are retired code or just not effective code yet. Okay. And then for the HCPCS validation, we have also one other validation for traditional Medicare. So for the HCPCS level 2, some of the codes are just not covered by Medicare, and they have explicitly said so in their fee schedules. So there are coverage indicator like IMS if you look into the HCPCS quarterly updates and download the files. So what each of them means is that basically it's not a Medicare benefit. It's excluded by statute federally, and it's not covered by Medicare policy. So in that case, we are also blocking it to you. But one way to override this is if you are acknowledging that this is a non-covered service and we want to submit this claim, you can add a GY modifier on the service lines and then bypass this block and get it submitted. So GY modifier basically means that this is a non-covered service and you're acknowledging do so. One of the use cases that you can for this is if the patient has both primary and secondary, and you want to submit to the primary Medicare so that you can send the EOB to the secondary for the secondary to get it paid. Then in that case, GY modifier will be acceptable here as well. Okay. These are the blocks that we have introduced. For the HCPCS, it's hard block. For the ICD validation, it's soft block. And how it shows on air is the first screenshot over here is the soft blocks. You can see it in yellow. And if you feel that this is just different for the patient's condition, you can click on skip and then skip it. Or another action is to remove the wrong codes or fix the ICD-10 code errors and then get it submitted. We encourage you to correct where it's applicable, where possible, but if it's really different and medically necessary, we can skip it. For the hard blocks, it shows up as a submission error in red, and these are not bypassable, but only for the HCPCS to validation for the Medicare. You can, as I said, you can add GUI modifier to bypass it. Okay. So that is the blocks that we've implemented so far, and as we continue to analyze our inflow, and we're looking through different blocks and validations that we can implement to prevent coding denials upstream. But the next really cool thing that I want to spend time talking about is coding suggestions. So we do get a lot of coding denials, rejections. Now, usually the workflow is we need either the coders working in the practice needs to review these claims, look at the medical records, look at the coding, maybe the guidelines, look at the treatment plans for these patients, and then correct those. Unless there's like a huge pattern of like wrong ICD codes that are incorrect for the guidelines, then in that case, they will be like, okay, this code needs to be pointed to the second position or the first position. In that case, our team can help you set up billing rules to submit those claims correctly. But most of the time, it just needs to get reviewed one by one. And if there's a change that needs to be done for the claim, you need to go back to the medical record, update the visit note. And so that's like a lot of workflow over there. So in order to help you with those and assist you, we are coming up with this next project, coding suggestions. So what it does is that how can we take all of these contexts, policies, and everything that needs to be taken into consideration to solve a coding denial, and then suggest a highly accurate suggestion to you so that you can easily approve it and deny it and change the payload automatically and then submit it. So one clarification that I want to make is we're not automatically changing the coding and resubmitting, and these are all like review process and suggestion for you. Currently, we don't have it, and we are currently working on it. So the context that we are feeding in here is that one, medical record, visit note, any other encounter medical files related to that patient and date of service. That's important to look at. Another one is the ICD guidelines, CPIC guidelines, modifier guidelines. We also have NCCI validation that's been currently in the system for over a year now. So that LCD, NCD, we look at the relevant articles to check back on the ICD-10 codes that are medically necessary, but also in the article, they also mention everything that needs to be done, like as a policy. So we look at that. We look at your billing rules and block rules and any other relevant claim-related rules. And for the claim, we look at the card clerks, the payloads that we submitted, previous claims that submitted for the patient for that insurance, how that claims were coded, the payer, and then we dry run all of those. Then we analyze those data and cross-check with the policy and then generate a suggestion. So when it is generated as a suggestion, hopefully we want it to be highly accurate so that you can directly apply it. But at the same time, it won't just be a note. We want it to be something that you can easily approve and deny. If you feel that it's a correct suggestion, just approve it so that your payload gets changed and then you can review the claim and then get it submitted. If you feel it's otherwise, we really appreciate the feedback that you can give to us, and so we can improve the coding accuracy as much as possible. Okay. Yep. All right. That's pretty much about the coding, and I think we will leave the rest of the time for the Q&A.
Awesome. I think we have one question from Colleen. When an eligibility/benefit returns incorrectly, what is the best way to handle that so it can be prevented in the future?
So This is something like we validate in our system, right? Like when we're looking at the eligibility check data, we are looking through those benefits. So if it's incorrect, one of the things that we are considering is setting up blocks if necessary, if that is like a requirement for sites. If you want to like review these details before the claim even goes out. Currently, we don't block claims, but this is something that we are considering for these cases where it's very evident that the benefit is inactive or incorrect. We would want like some level of manual review there. So that is something that is actively being considered. Any other questions, Tweet?
Sorry. And what should we do in the case where the eligibility responses are inaccurate in itself?
When the eligibility responses are inaccurate in themselves. So that's the thing I was saying. Like we do have like validations to make sure that the response is accurate, and if it's not, we will not affect the claim. We will leave it. We will let it go as is, unless we're actually sure that it is incorrect. In which case, we could like set up blocks. But by default, the claim would go out as is. We don't want to make the wrong changes on the claim. We only make changes on a claim when we're completely confident that this actually will prevent a denial or a rejection. So yeah, that is how we kind of like operate right now.
Okay. Dove has a question. Does Athelas detect in a policy if a policy is in the grace period for non-payment of premium?
I'm not sure about this. Jasu, do you have any idea about this?
We currently don't track this to see if it's non-payment of premium.
And this is because there are some dependencies of the data not being returned. Is that accurate in the eligibility responses?
Yeah, eligibility checks, not like we're trying to use as much of the data that we have, but a lot of payers do not actually like return benefits details in detail. So some of it is not possible just purely because the data is missing. But whatever is there, we try to use it to the best that we can.
Awesome. Another question. Could Athelas put into place Medicare patient blocks? Medicare allows routine screening once every 10 years. However, if a patient has high risk reason like history of polyps or family history of colon cancer, Medicare allows once every 2 years. Are these some of the checks that we could potentially put in place?
Yeah, I think we can definitely like have like Medicare blocks in place. This would be through our rule engine more so than like enrichment or coding. But yeah, I think this should be possible.
And I would say if you have a request like that, please send it through to support, and we will review and pick that up.
Yes.
All right. That's another question. Will it eventually be possible to place a block or alert on the clinic side of things to prevent or notify the providers not to use excludes one or other coding conflicts versus blocking them on the claim working side?
Yes. So for sites that are on our AIR EHR, we are currently working on that validation on the clinic side. So before the encounter gets closed and provider closes the visit note, we're going to be alerting those ICD-10 conflicts so that we can just have the right medical records and close the encounter and then get it submitted without submission error. And for our sites that are not on AIR, we don't have a plan to do so. For AIR, we will have that validation very soon.
Awesome. And I believe that you answered a similar question prior, but could there be a block for Medicare patients in the eligibility prior to services? For example, if a patient is not eligible for screening colonoscopy, office needs to be notified prior to having the procedure.
Um, uh,
So
I
service
think we'll
level.
have to like review this actually. I'm not entirely like sure of that context. Like we'll have to like actually look at the data in the eligibility check to see if we could prevent this. If the data is not available to us, it might be a little complicated.
Awesome. Another question that we have noticed eligibility on several other patients in which they are incorrect. How do you plan on improving this?
Yeah, so we do have like an eligibility team. Obviously, there is some level of setup when it comes to eligibility checks and their accuracy. We do have a team that is actively working on making sure that the eligibility responses themselves are accurate. Like, the payer setup is right. We trigger the eligibility checks with the right inputs. So that is already being like continuously improved. From a perspective of enrichment, there's obviously like RCM is a world of edge cases, and we've tried to account for as many edge cases as possible through our back testing process across like a wide payer mix across a whole host of different patients. But there might be like a few edge cases that do come up, and that is something that I guess Elliot mentioned, right? Like we do want to like continuously improve the accuracy on that last little bit to make sure that all of these claims are going out incorrectly and we are going out correctly, and we're making sure that the right changes are made. So these are things that are being continuously improved, have like really good guardrails in the system. One of the things that we actually noticed during this process of testing was just how messy the data is when it comes to eligibility checks. So you do want to make sure that the system itself is like protected from all of these things, and that is like an active effort that we are taking on. So you should see like we've already like improved the accuracy like drastically over the short period that it's been live. So you will see that accuracy keep continually growing because we do have like a self-improving loop in this process.
Thank you. There's another question. On codes that are not covered by Medicare, do we accept those modifiers such as GA as well as the GY modifier? And how does that interact with our ICD and CPT checks?
For the HCPCS that are not covered by Medicare, currently it's only the GY modifier, because the nature of the blocks here is, for example, the coverage indicator S is excluded by statute, so it's GA is not accepted over here. You can have GX along with GY together. For the coverage indicator M, it's also not covered by Medicare, so you can have GX along with GY, but its GA is it's like you're expecting that the patient will pay like for sure. So yeah, it's only GY. So if you want to use GX, it needs to be used along with the GY. So in the end, you have to use GY.
Okay. Another question. Is eligibility enrichment and what we discussed today only available on air?
No, this is available across all of our sites. It is live for all of our sites, including Air. So yeah, you can. We have the support for both Air and non-Air. What we look to do through Air, we do have a lot more control in terms of like the data. So we are able to leverage more when it comes to Air. So that is an inherent property of Air, but eligibility enrichment looks at eligibility check data. So this is available for non-Air as well.
Awesome. Next question we have. Are there plans to add home hospice episode checks to the eligibility checks so we can flag if a Medicare patient is within home hospice dates?
Yeah, hospice is something we are actively considering. Yes. So there is like some signal in the eligibility check when it comes to hospice. And we are like actively reviewing if we can like incorporate that to flag those cases to the user before the claim gets submitted.
I have a question about primary diagnosis codes. We currently have blocks in place for invalid primary diagnosis codes. However, for certain services, the primary diagnosis is required to be a chronic condition. Do we have any valid or edits in place to ensure that the primary diagnosis meets the medical necessity requirements for these service types? You're on mute, Jasu.
So we understand that there are some codes that is medically necessary to be primary diagnosis code. But for the ICDs that we have blocked so far it's very highly likely that it should not be primary diagnosis code. So for the cases that sometimes can be primary, we did not block those cases. For the ones that we blocked, we're very sure that this should not be primary diagnosis code. But if it really is very patient specific, very medically necessary, then you can override to do so.
Right. The next question that we have, when there is an eligibility or name error in the EHR, how does Athelas handle it?
When there's an eligibility like name error, did you say? Sorry.
When there is an eligibility error or name error on the EHR, how does Athelas handle it?
I guess like could we like elaborate on what kind of error we're thinking of? I'm not really sure.
The question is a bit vague, and so I would say, do we make corrections back into the EHR, or does it just change within our system?
Yeah, so right now, yeah, so we currently, so the fundamental like assumption is that you should always verify the data that's coming through from the EHR. So that is the purpose of enrichment. So we'll verify the data, and then like the data that's coming through from the payer through the eligibility check, we try to like validate and then make those corrections in our system. We're currently not like writing back to other EHRs, but this information will be written back to AIR, so that all of these like insurance updates, all of these like incorrect patient subscriber details are automatically updated in our system. So this will be supported on AIR. Non-AIR, we will essentially provide reports of what are the different changes that we think are right, and these are the changes that were made by enrichment, and then the site would be, or the client would be able to essentially write that back to their EHR so that going forward all of the imports are correct.
Awesome. And once a change in demographics is updated, is it permanent?
Once a change in demographics is updated, it's not permanent. You could still like update the information.
Does it impact net new claims that go out for that same patient?
Yeah. So one clarification here is we're not updating the patient profile automatically. We're only editing the claim based on eligibility checks. So the patient profile is not updated.
Awesome. How do we handle insurance companies that require a phone call for eligibility, such as UMR, Ascension, etc.? Are these excluded from the eligibility enrichment checks that we have?
Yeah. Right now, like our eligibility checks are, this is supported for eligibility checks that are electronic. So this is through our like different like third-party vendors that we have, like UHC. We do checks with UHC, Waystar, Availity. So we have a bunch of different like vendors who we do it with. Those are all electronic. For the ones where we require like manual calling, or any like form of like comms with the payer, like we do not support enrichment for those payers.
We do have an eligibility team that
Mhm.
does do these checks manually and enters it within the Insights platform.
Yeah.
Awesome. Next question that we have is, when will this be implemented?
This being because both eligibility enrichment and the coding validations are live. All of the what's next portions are essentially parts that are on the roadmap and should be live in the short term.
Great. Another question. What about Medicaid family planning and emergency care only? How can we identify and block these patients or claims?
Medicaid family emergency plans. Not don't really have context there. We'll probably have to like get back to you on that one. We'll probably have to like review this particular case. Unless Jasu, you have anything to add?
Yeah, we'll review and get back about this.
Okay. See, I think there's a question about authorizations. How are authorizations handled prior to a visit or during a visit for those that require them for procedures or DME? I would say this is a great question. We will send you a follow-up email after this call with more details here on the authorization process and flows, as the session is dedicated primarily for eligibility enrichment and all of the ICD checks that we're rolling out. Okay. And last question, if Medicare Advantage is active and listed as a primary payer, but Medicare remains on file as a secondary, claims are still being sent to Medicare unnecessarily. Do we have any validation to prevent this?
So currently, like I said, we don't proactively like block. That is actually something that we're considering because we do get these signals, but we also don't want to block incorrectly. So right now, our goal with enrichment was to make sure that initially, when you're submitting to primary, we're sending it out correctly, and then these other pieces of like, yeah, just because you submit this to primary, what else should get corrected? Like those are pieces that we're still like working through, and like we want to add those like validations in as well.
Okay. All right. I know that we are at time, so thank you everyone for attending. If we were unable to get to your questions, we'll be sure to follow up via email just to make sure that your questions are answered. Thank you all.
Thank you so much.
Thank you so much for taking the time. Appreciate it.